So this is a 45-year-old male. He had RTA a year ago. He had a PCL avulsion, which was missed or conserved, I don't know. But he landed up 1 year later with instability, pain, and intermittent swelling. These are his X-rays. This is his stress view. It was a grade 3 posterior drawer on X-ray. So these are his CT scans. The 2D sections in all 3 views and the 3D section. It clearly shows a non-union of the PCL fragment. It was a very big fragment, and definitely the patient had instability. So as we do this routine trauma, managing this PCL avulsion non-unions is also an important point. These are rare injuries, but they still occur. Small PCL avulsion fragments, they heal, but larger ones, if they are not fixed, they usually go in non-union because the forces are too high. And the smaller fragment has some soft tissue around it, which keeps it in its position to heal. But a large fragment, it rarely heals if it does not fix. So there were many options: arthroscopic reconstruction of PCL as it is a late presentation, and arthroscopic fixation, or an open repair. So I did not do anything different, just sharing this case. So this was done by a routine Berk-Schaffer approach, open approach. The PCL was, means as we exposed the PCL, it was, so I think, so this is a very small video where we can see that the fragment was still mobile there, just to show that. And a very important point to highlight that whenever we are in this very small location and we are doing this non-union repair, we have to remove all the non-healing or the fibrous tissue from there. So we need very appropriate instruments. So what I learned from this case, that we should keep our spinal roungers from our friends who use this small forward or side cutting roungers to remove the fibrous tissue from that very small space, so that you clear the fibrous tissue and you sit your fragment in its place. So this is a rounger which was used to remove that, and it was this fixed with these 2 screws by routine fashion, a compression mode, 6 weeks post-operative X-ray, a year post-operative it healed. But one has to remember that you can, in a late presentation, you can convert a grade 3 posterior drawer into a grade 2. You cannot get the great stability with, as happens with a normal PCL, because the PCL is already stretched with this ligament. So these are some papers, few papers, but they are there. So take home message is that symptomatic PCL avulsion non-unions are rare, but they do occur. Pain, instability and swelling occur. Appropriate non-union repair following the basic principles as we do for our routine non-union repairs have to be followed, and compression has to be there. So this, thank you.
Thank you, Vijay.